The broadcast is now starting.
Good afternoon, everybody, and welcome to our Wednesday webinar. This one is on BRITE, the Brief Intervention and Treatment for Elders. This is a Florida project that Dr. Hazlett has implemented there. Dr. Hazlett has 39 years of experience in mental health, behavioral health, and the addictions field, and he's responsible for implementing and training SBIRT initiative in Pennsylvania and Florida. He's also worked with many other states to develop their SBIRT programs. He is a consultant in Florida right now, and I will transfer this to Bob. Okay, Dr. Hazlett. Click on the boxes in the middle of your screen.
Okay, we're ready. Well, good afternoon, everyone. This afternoon I'm going to be talking about not only the Florida BRITE project, but actually it's the SBIRT project, because BRITE is basically Florida's SBIRT. And BRITE actually works with the 55 and older, where SBIRT can work with all different ages. As a matter of fact, Florida for the first 3 years was 55 and above, and in the last couple of years of the grant went to the 18 and above. I know I've worked with New York. They've been working with the 12 and older. And so basically when I'm talking about successfully implementing the BRITE, it's about successfully implementing SBIRT in general. And I'm going to be talking about different levels of implementation. For example, some of you I see are from state entities. Some of you are for local county entities. Especially if you're going to be applying for the SBIRT grant in the future, there's some things that you basically need to know to be successful. And one of those is that in your grant, you need to specifically be working with primary care as well as other agencies, but the focus is on primary care and the health initiative. And the reason why SBIRT was established, it found that other things like tobacco, alcohol, and illicit drugs are among about the top 20 risk factors for ill health, identified by the World Health Organization. It's estimated that tobacco is responsible for about 9% of all deaths and for about 4.1% of the global burden of all disease. And this is measured as the number of years spent living with the disease, which we call disability-adjusted life years, dailies, while alcohol is responsible, we know, for 3.2% of deaths and 4% of dailies. Illicit drugs are responsible for 4% of deaths and 8% of dailies. We know excessive alcohol use, other substances abuse are also risk factors and are widely variety of social, not only financial, legal, and relationship problems for individuals and families, but globally there is an increasing trend for people to use multiple substances, either together or at a different time. This is likely for further increase in the risks and the risk factors. And you know, we're going to be talking about primary care, but we're also going to be talking about other agencies that can implement this. For example, adult protective services, social service agencies. Anyone that basically has an intake process can implement the SBIRT process. Primary care workers are in a unique position to identify and intervene with patients where substance use is hazardous or harmful because they're the first line. And the reason why we know this, that in the developed world, 85% of the population visits a primary health care clinician at one time or other. Patients whose tobacco, alcohol, and other substances use is hazardous or harmful have more frequent consultations. And this means that primary care workers have the opportunity to interview as early stage before serious substance-resistant problems and also health-related problems. We're talking about, like here in Florida and in your states, you have senior center programs. A lot of the senior center programs consist of not only nurses and physicians that work with the older population, but also social workers, intake workers. There's substantial evidence of the benefits of screening and brief intervention for alcohol problems in primary health care settings. We've proven that over the years since SBIRT has been a factor. The World Health Organization says that a 5-minute brief intervention can be just as good as a 20-minute counseling session. So basically, the evidence is there, and all this information that I share with you, there's more extensive information in SAMHSA. So when you're getting ready to present this to a potential provider, a healthcare entity, one thing is to be prepared to have that kind of information, because the first thing they're going to do is ask you, why should we participate in this project? So let's go ahead and start and begin with what you can do. First of all, if you're going to be writing a grant or if you're going to be looking for potential providers, there's a lot of information that you can gain by going onto the internet for potential sites. First of all, you need to pick and choose what populations you want to serve. For us in Florida, we picked the 55 and above. In Pennsylvania, we start with the 18 and above. New York, 12 and above. I'm working with Virginia now with, I know I saw on the registration there's someone from Virginia. I've been working with the Center for Excellence in Aging. They have BRITE and SBIRT project going on. They weren't very lucky this year. They didn't get any of the funds from SAMHSA, but they're still continuing on. And this is because there's our foundations that are available. That's why I have here the Foundation Association's possible research to ensure sustainability. If you do get a grant from SAMHSA, sustainability is talked about day one. And we found that if you research hospitals, a lot of hospitals do have foundations associated with them. And in Florida, we were lucky that one hospital did, and when the grant money went, they took over the funding, besides billing health insurance for the screenings and brief interventions, and also Medicaid in our state. We're unlucky because in Florida, we have Medicare codes turned on, but the Medicaid aren't at this time. There's a lot of states out there. I looked over the list. You have both Medicaid and Medicare codes turned on, which is good. So basically, when you're getting ready, these are the kind of things that you need to look for. And when you're ready to prepare your grant to submit to SAMHSA, it's best to make sure that you have some of those entities already on board, because their letter stating that if this money is provided for the state, that they're going to participate in this is very helpful. All those letters of support to go in with your grant proposal gets you higher scores and helps you get some of the money. Lucky you'll get some of that money that we did in Florida. We got $17 million to initiate the SBIRT process. Okay, so once you've decided and you've looked at somewhere where you found some resources and you found some providers that you want to solicit to get them started, and you want to implement the SBIRT or the BRITE, as we do in Florida, the potential provider sites recommended, basically we're looking at hospitals, ERs, outpatients, inpatient trauma centers, multiple physician practices. Why? Basically because what I said before, we found 85% of the people do go to their physicians. We want to reach as many people as possible. So these are the places that you'll have the most population. Multiple physician practices, urgent care centers. A lot of people never thought about that. Here in Florida, I got on my horse and went out throughout the state of Florida and brought on urgent care centers. health clinics, HIV health clinics, federally qualified health centers can be potential providers for you. Senior care centers, mental health programs, university health clinics, admissions departments, adult protective services, university health clinics. These are all important. I noticed as I looked at the registration, there's different types of programs that signed up to participate. We have social service agencies, we have some hospital people, we have some state people, some local people. It's very important to know that this process can be implemented in all kinds of settings. Colleges, high school, health clinics in the high schools and the colleges, wherever you decide to do. In Florida, we actually had, for a while, we had a mobile unit. Physicians that had a mobile unit were going out and actually doing the screens with their mobile unit. So these are ideal situations. Now, the issue that you have when you go, once you get these provider sites that you chose, setting up the meetings is the next important process. You have to make sure that you have everything ready for these meetings, because this is going to make or break you. So the next phase of this is, once you've found your potential provider sites that you want to solicit, you need to send your salespeople there. And I'm being honest, they need to believe in this project. They're going to have to sell this thing. They have to be good salesmen and sincere when they are presenting this. So the next thing that you need to do is you need to schedule the initial marketing meeting with your potential site provider. You have to have authority for discussing potential revenue. When I went out, I had the authority from the state. We went out and we were able to give out grants. If you're a state entity or a county entity and you have the money and the authority to do that, we were able to give out $150,000 to each site without going through the lengthy process. If we had to make it more than that, like to $300,000, we ended up having to send out RFPs, having people participate. But when you have those smaller amounts, depends on how your state runs, we were able to go out and talk to those entities and say, this is what we can offer you to get started. If you have that in your basket when you go to these meetings, money does talk. Let's be honest about it, especially when not only do you have the Director of Business Development, they might have their fiscal people there at the initial meeting. But it's key to have, like, the Director of Business Development, the Foundation CEO if possible, a Medical Director, Vice President of Operations, Hospital Administrators, and I'm going to be talking about the last two asterisks I have there. The thing is that these people are the ones that are going to make the important decisions about whether they're going to go ahead and look at your project, you implement it there, and you're going to have to come up with some good statistical information to share with them. I'll give you an example of how successful you can be. I was scheduled for a meeting at one hospital. I talked to the Assistant Director of Business Development and explained to her who I really would like to have at that meeting, if she could set that up. She says, oh yeah, we'll have the medical director and we'll have the vice president there and all that. And I thought, that's really great. And I showed up to the meeting, and there was only the Assistant Director of Business Development, and the person that came, the other person came was late. She came from one of the other hospitals because they own two hospitals. And she was a nurse, but she was like the ER director and master's in nursing. She came in, and I started talking, and I says, do you know why you're here today? And she says, no, I have no idea. I was called, and I was sent over. I said, uh-oh, there's one strike against me. So I started to talk a little bit about the benefits, and she wasn't even hearing me, especially when I was talking about the money they can save and about the individuals that use the ER as a revolving door for other problems, and how it takes away time from the serious patients. Because all she was saying, we don't have time to do this project. We have to get these people in and out of the ER, and my staff is this and that. She was completely against it even before we started. But if I would have had possibly the fiscal person there and the physician, medical director, and other people there, they would have looked at it maybe a little bit differently. So after that, I said, okay, well, I'll just take my pots of money elsewhere. So I went to the local physicians that own several urgent care centers and sat down, talked to them about how it is, and said, well, we can just implement this in our application process, intake process, and gave them, $300,000 to get started. So the hospital turned down that kind of money, basically because the people that needed to be at that meeting wasn't there. So it's really important. Because the other thing that you have to do, if you're offering money, that's great. Some of you I know out there aren't, and you want to get this thing started, and you have to sell this. If you have the money, you can do the direct contracts. If you don't have money, you can work up a memorandum of understandings or collaborative agreement where your staff can come in and assist and do the screenings and do this part of this with the staff that's already there. And the key thing when you're doing this initial marketing meeting, or even when you're soliciting for these sites, is that the SBIRT process, the BRITE process, SBIRT process, is there to be integrated into their system. Just like I tried to talk to that nurse manager, that there's nothing more to be done except what you would do if a person had diabetes. You would sit there and talk and give them a little educational spiel about the diabetes and the behaviors that they're having, how they need to be looking at that and changing it. It's the same thing when you're looking at someone that's misusing. And in Florida, not only do we talk about misuse of drug and alcohol, but we also talk about misuse and mismanagement of prescription medication. That's an additional thing that we do here in Florida. So this is the key thing, is getting started. Now, one issue there is when you do this, for the state people that have grant monies, for you out there that do have grant monies, you have a white elephant in the room that sometimes makes it a little difficult, and that's called the GPRA, the Government Performance Reporting Act. So if you have the $11,000, $17,000, or whatever monies from SAMHSA grant, you're going to have GPRAs completed on screenings, brief interventions, treatment, and referral to treatment. Those GPRAs have to be completed. And you know that the physicians aren't going to sit there and complete those. So you have to work with that staff to find out who's going to be doing what and how this can be integrated into it. Now, over the years, I've developed a process to be able to use the GPRA questions along with some of the screening questions, because this is the issue. If you do the pre-screen questions, which we're going to talk about what pre-screen is, and the screening questions, then you go in and do a nice 15, 20-minute brief intervention and get dialogue with the patient, and then you come back to them and say, oh, by the way, I've got to ask you another 10, 15 questions about your use of substances, because that's what the GPRA does. So you learn to integrate it into your a screening and assessment process. And also, I don't want to scare some of you out there, because the GPRA is not that difficult. The screening questions go anywhere from 5 up to 9, and all these can be placed on a tablet PC with the person inputting the data, just clicking on the answers, and then at the end it automatically scores the screening forms, scores the GPRAs, and records all that data. And a little screen comes up and tells the person what intervention needs to be completed with the patient. So it's going to be important if you're going to get involved in this to have good IT people there, because basically the program is under Access and Excel. And I can assist you with that, and I'm sure Iretta can assist with that. We can get that program up and assist you in getting that program onto your tablet PC so that you have that data. And what's nice is once it's in your tablet PC, that data can be sent to your evaluator that's evaluating your program, and also down to SAMHSA for their statistics and for their data collection. So it's all compatible with that. So I don't want to scare you when we talk about the GIP reforms, but that's the reality for those of you that have that. Okay. Let's see. Let me get that icon out of there.
Bob, you probably won't be able to do anything to it while it's in the slideshow mode.
That's right. Okay. Well, it'll go away once I go. I'm going to go to another, hand app that I found here. Okay.
Okay.
So I'll just leave that there. I apologize for that. The initial meeting with potential provider sites. When you do that, when you have your initial meeting, another thing to have with you is an informational handout. Chris was nice enough to send those out last night for those of you that might have gotten them already. That handout is vital. It talks about why we use this in primary care. It talks about what they need to get started. It also talks about what ideal models there are that they can choose from. And it also has the screening tools that you're going to use, that you decide to use. See that. And it's an important part. And plus it gives them a resource once you've left there. And again, the salesmanship is going to be very important. And to use champions. If you have somebody from another state, someone, or in your state that has worked with this, I was lucky enough, I spent 3 or 4 days with Dr. Bernstein and the University of Boston's Project SBIRT. I worked with him and his staff, and after I left, I helped him out with some things, and he helped me out by I had a conference call with a hospital entity with everyone in there, and Dr. Bernstein helped me out by talking a little bit how it benefits the physicians and how it benefited them at the hospital, and he did it for another meeting that I had with another hospital entity, besides myself being there selling this. So if you have champions, use those champions and bring them with you. And there is so much success with this project now because it's been there for 10 years. Dr. Bernstein's been doing this since 1990, and we began with this SBIRT around 2003 with SAMHSA. So you can see there's a lot of good information out there. And basically, when some of the money's left here in Florida, the doctors that own the urgent cares started billing the CPT codes, but the doctors continued to keep it because the one doctor told me it's the right thing to do. There's just a few more questions on our health assessment when they first come in, and then all his staff was trained in doing brief interventions, even the x-ray technician. So some doctors really buy into this. And also we have, we now have resident programs out there. When I was in Pittsburgh, even before SAMHSA was funding, specifically funding and looking for resident programs to do this project, I actually trained 7 residents at the Mercy system, and these residents were involved in doing brief interventions and the screenings, and started out with that. Now we have resident programs all over that are working with the SBIRT model. Okay, so the next step is you've sold it to the provider. They want to get involved in this. You're going to go in and you're going to assist them. You can give them the BPA, which is the Business Process Analysis workbook that was a handout that Chris sent out. And basically, this is a vital piece of information that you can even go in as a team to assist them in completing this, or they can do it all on their own. Basically, this is the plan. This will help them set up the model. This will help you determine who needs to be trained if you're going to be training the individuals. So why don't we begin to take a look at that business process analysis plan and talk about basically who should a BPA involve. Well, generally the business process interview should be attended by most of your senior clinical and administrative staff who can explain how their healthcare system operates on a routine basis. Identity, well, actually, ideally, a member from each sector of the healthcare team should be representative. If they're, for example, potential, if they first come in and they see a receptionist, maybe the receptionist can actually administer the pre-screen, because when you're talking in large practices or emergency rooms where there's multiple, hundreds of people going through there, especially in an emergency room, a pre-screen, evidence-based pre-screen would be beneficial to use. So it'll weed out those individuals that are negative, because there's going to be a lot of them unless you're in a certain area of your community. When also they can each individual has a valuable perspective, knowledge of it. The nurses do, the medical assistants do. So if someone representing that knows how the routine goes is an important person to be there. Then the process itself, there are basically three parts to the business process analysis. The first part consists of modeling the clinic or unit workflow by describing a typical course of an appointment from a patient's arrival to departure. Patient comes in the door, walks up, gets papers. Maybe you can put the paper, we call them extended healthcare questionnaires. And they had the quantity frequency questions in there from NIAAA, a couple questions on drugs, and we had the PHQ-2 on depression, because we did depression here in Florida. We were probably one of the very first states that started doing other than just drugs and alcohol. So we had those questions on there. Or the situation might be, well, yeah, they see that, then a medical system takes them back into a room and does triage. They take the blood pressure, weigh them, ask them questions about their health, and then they send them back into the waiting room waiting for someone to call them back into one of the exam rooms. So this stuff needs to be documented, so maybe that person can do an interview screening with them, okay? So knowing how that works is important, and showing them that this is how we're going to do it. We're going to integrate it. This is going to be integrated into your system, not your system into ours. So that work, the process itself, the third part is the description of the operational and logistic support system, such as clinic hours of operations, access to fax, telephones, internets. Now, we use tablet PCs. Well, in a lot of the hospitals and even the urgent care centers, each room has their own computer. And this program that we use for the data collection can be loaded onto those computers. So as they can, ask the questions and put the data in right there, the screen will tell them what intervention is needed right away, and the interventionists can, do their 5 or 10-minute intervention, or the physician, or the nurse. A lot of programs that we had, especially in Pennsylvania, we had physician practices, we had physician assistants doing screenings, brief interventions. Some places the social workers are doing it. So again, it's going to be what their process is going to be. So you have the workflow analysis, and is the next process and step to create a flow chart. Let me take a look. I'm going to show you this. Okay. On the workflow analysis, you want to check to make sure, does the clinic operate? There we go. It should go away now.
Bob, I'll tell you about, while you're getting rid of that icon, can I just do the quick poll questions I have?
Sure.
Yeah, and that way you can work on getting rid of that. Okay. Okay, everybody, this is Chris again, and if you've been with us in the past, you will know that we have some brief polls that we would like you to participate in. Here is the first one. These are real fast. And it's just a way for us to get an idea of who's attending our webinars. So this is the first one. Please click on what represents you best for your current role. Are you a counselor, therapist, social worker, or case manager, nurse, nurse practitioner, physicians or physician assistant, program or unit administrator, university student or faculty, or other? And if you'd like us to know what other is, you can just type it either in the chat or the questions box, and that way we'll have it recorded.
Okay.
Get rid of it?
Yes, it looks like I got rid of it there.
Okay. Yeah, we'll just finishing this one, and then I've got the 3 others that are real short.
All right.
Okay, I think it looks like everybody who wants to has participated in this one. I'll close it and share the results. So, Bob, of the looks like 17 people who are here today, 50% are counselors or therapists, social workers, or case managers. We have 8% in the nursing or physician category, another 8% program or unit administrator. See, I have a typo there. And then another 8% are the university students or faculty. So there's a 25% other, which is pretty high. One is an interventionist policy advisory board member for the Georgia SBIRT Basics grant. So thank you very much. That gives us an idea. It's, we've got people from each category, which is nice. Okay, now here is, here's the results in case you wanted to see what category you were in. Okay, now I'm going to share, or I'm going to open the second. No, this is still the first one, isn't it? The second. Okay, here we go. What field do you represent? Mental health, addictions, physical health, education, or EAP? Okay, I think everybody's answered that one, so I will share the results. Bob, in the audience today, 31% people are in the mental health category, 54 are in addictions, 8% physical health, 8% education. Okay, now they get real short, so this is going to be really easy. You don't have to think too much. Do you conduct SBIRT interventions now? This is simply a yes or no. Okay, I'll close this one and share the results. Okay, Bob, 36% currently do SBIRT and 64% do not. And our last one, does your agency use SBIRT now, or do you see them using SBIRT in the future? Yes or no? Okay, great. Bob, I'm sharing this one. Right now, 77% of the audience's agencies currently use SBIRT or are planning to use SBIRT in the future. 23% say no. So that's it for me. You can, yeah, we're back up to you now. Thank you, everybody, for participating.
Okay. Towards the end of this, I'm going to be also talking, since those polls give me some information to share, is that why it's important for entities to come on board with this SBIRT because of the new JAGO standards, and I'm going to share those in a minute. But getting back onto the workflow analysis from the Business Process Analysis Plan, this BPAs will help you to be successful when you're implementing this and when you're going into a program to get this implemented. First of all, does the clinic operate on a fixed appointment or is it a walk-in basis? If both, what is the mix between the appointments and the unscheduled visits? How does the client report or sign into the primary care visit? And it doesn't, when you're using other entities, it's not the primary care visit. It could be your social service agency. If they're coming there for mental health, even mental health has their own health screening questionnaires that can be used, and I'm sure the PHQ-2 is familiar with mental health, those two questions into the pre-screen if you're using pre-screen, or the full PHQ-9 can be utilized as part of the intake process. So again, like I said, this can be utilized in any type of setting, but we're just talking right now about the primary care because basically if you're getting that money from SAMHSA and you want to be part of the project, the focus is getting primary care involved in this as well as your other agencies. What is the patient's average waiting time before seeing the doctor? A lot of places that I went into, the medical assistants actually did the screening, and when in between the doctor's visit, they would go in and they would do the brief intervention, or the physician would come in and do the brief intervention. And a lot of people says, well, you know, there's going to be much resistance with this. It's the opposite. When I talk to patients and we do some satisfaction surveys, they say they were really glad to have someone come in and talk to them because sometimes they sit there for 10 or 15 minutes. I've done this myself, and you're sitting there on the table and you're looking at the doctor's credentials or you're looking at stuff on the wall. So, and also if you've got a bellyache or a little ache or a pain, it helps you keep your mind off of it. So there's a lot of different experiences that you have. And if you're a mental health person, a drug and alcohol counselor, this is going to be a different setting. If you're going to be working, if you have a memorandum of understanding where your agency goes in and helps do this, you're going to be in a fast-paced environment, moving from one exam room to the other, also, another thing that's very important to be successful, the people that are placed into there have to deal with gross things. I mean, you see auto accidents come in through that ER room. Of course, you're not going to be working with those type, because the physical issues are the first thing, but you'll see that. And we had one person that was a social worker got involved in this, never worked in the ER, but wanted to do this project and got there, and she quit after a few weeks because of gunshot wounds, severely broken extremities, bones sticking out. It's a different environment than sitting down and doing an hour therapy session. Okay, so that's the workflow analysis, and then the next part of your that is you can help them chart that using this chart here. Check-in reception desk, no wait, remaining waiting room about 10 hours. This is just kind of an example for them. And when you show them, take this workbook with you. And then the next one is the actual patient flow diagram sheet. Okay. So this works, and you can see the next one on it. You have this handout. I'm just going over it very quickly. It's the staffing, primary care providers. You write down all this information here. Administrative staff, etc. And then before you close, again, this is the BRITE team. We went in as a team. We sat there and we asked if they have any issues or concerns. We jot all this down, and then we come back together with the, most of the time it's the director of the ER and some key administrative staff from the hospital, and determine what the model is going to be, whether they're going to use the nursing assistant that does the triage to do the screening forms, and maybe the nurses are going to be doing the brief interventions, or the physicians are going to be the brief interventions, or they may have the hospital social worker being involved. If they do all the screenings and stuff, but if there's an intervention needs, they call the social worker down to do the intervention right there. But they have to be available there, right on scene, because you've got to get them while they're still there in the hospital. Now, the issue is if the GIPR has to be done, somebody's going to have to be asking the GIPR questions, so you have to determine that. Again, from it sounds like there's people already have been involved in the SBIRT. They know what the GIPR is all about. Just finding that person do that. Now, some hospital entities hire people from the outside to another additional staff to do the GIPRs or the paperwork. It's all what is going to work for that program and that entity. So you have to be flexible and to make sure that it's going to work. Okay, on that. Okay, so we talked about the BPA, the Business Process Analysis Plan. Okay, so you've determined what the model is. Hopefully, before you even get started, you have your own curriculum available to do what we call an SBIRT toolkit. Chris can tell you I coined this phrase way before a lot of people on the field, calling it the SBIRT toolkit. That consists of your training manuals, all your laminated visual aids that you're going to use for working with the patients. It's laminated visual aids really help, especially when you're working with the older adult population, showing them on the charts. So all of you that have been already working and that have your visual aids probably already available. If you don't have those, you can get them on our website. Also, I'm sure there's visual aids that are available there through IRETA and through the National SBIRT ATTC. there's things from SAMHSA that you can get a hold of. Or if you need some additional help, just email me and I'll try to help you out the best I can. The training manuals are basically a very good resource. When I developed the training manuals, I developed from the beginning, and I developed for basically at least a 2-day initial training, okay, to get them started. Educate them and train on using the skills, and the training consists of on-hands experience also. You know, the adult learning model that we use in all of our trainings. So the training manuals are important, have all that information in there about the pre-screens, all the research that goes with it, the actual screening tools themselves. There's so many of them in Florida. For the older adults, we use the Assist, and I think the Assist is a very good one because of it can be used for 18 and above, because the requirement from JACO is tobacco, and that's the first question on that tobacco is on the Assist. So you can get that scored as well as all the other drugs. So I think the Assist is a very good one to use for in the future. So training manuals are important. Your laminated visual aids, make them big enough. What we did in all our training materials, we got them transcribed into Spanish, Creole, for down here in Florida. So those are available. Our laminated visual aids are available in Spanish and Creole. We work closely with the University of South Florida. Dr. Schoenfeld, myself, and some others, we were able to get these all translated in different languages. Also, additional training is very important. We start out with a 2-day initial training. The motivational techniques we train them in are the basic ones to use to get started, are the readiness roller, confidence roller, you know, the negotiated brief intervention, all the motivational things that they can utilize. But then what we do down the line is we give them more advanced training in motivational techniques. Okay, we use webinars just like today, webinars, and also we did training seminars and train the trainer. Each region, I went to each region and brought the programs together. They sent people that went through the initial training and they thought would be good trainers, so that the requirement was for them to have gone through the initial training. They sent them there and so that I could train them as trainers. So that's a very important thing. It all depends on how many is in your staff. Me in Florida, I was the only one. I went out and secured sites. I went out and did all the training. When we, at the end of our grant period, I was able to bring on about 25 contracts. They started with 4, and then I ended up with 25 contracts, but with 65 sites throughout the state of Florida. You know, providing SBIRT services, which is BRITE for the 55 and older. Then a key thing for being successful in implementing your SBIRT or your BRITE project is mentoring and supervision. Okay, I had to go out and mentor, and especially in Pittsburgh, I had a few nurses that was very gruff. They were medical nurses, and they expected to get things done when they say it's getting done, and training them in the motivational techniques and showing them how, you know, they can get people to look at making changes and do that on their own. And so I had to spend a little bit more time going out and doing some individual one-on-ones, and supervision is very important. But when I say supervision, what I did is I made myself part of their team. I wanted them to feel comfortable when I walked in there. And I'm going to be talking about those quarterly reviews in a minute. But under the mentoring and supervision, there's core competencies that need to be established. We established core competencies when I was in Pittsburgh and with IRETA at the time. I assisted in developing those core competencies. As I moved to other states and into my program here, I continued with those core competencies. Had to adjust them a little bit based on the population or the agency that we're working with, but those core competencies need to be there, and whoever is supervising at those sites need to be aware of those competencies and go over them when they do their supervision with the nurses or healthcare educators. That's an important factor too. I need to bring in at this time. If you're going into primary care or emergency rooms, I don't care, like myself, I have a PhD at the time, I was certified clinical supervisor, certified addiction care, all that stuff does not matter to those patients. You need to identify yourself. I would go in and say, hi, I'm Bob here, I'm part of the healthcare team here, and I want to ask you some extended questions that are related to your health, but they talk about prescription medication you use, drugs that you may use, alcohol, because it's vital, because the doctor may want to prescribe something for you, and what you're taking now could interfere with his treatment and can interfere with your health. And our main concern is your health. And these questions are confidential between you, me, and our team here. Would you mind me asking? No problem. And this is how we train our people. And on the name tags, it's not mental health licensed social worker. On the name tags, healthcare advocate, healthcare educator. They need to know that, because they're not there to be seen by a drug and alcohol counselor, or they're not there to be seen by a mental health therapist right there in the ER. They're there because of health-related reasons. So that's why SBIRT is very effective when you take it into that kind of setting and use these kind of procedures with the patients. Okay, so you need a checklist. I recommend the supervision checklist be done within 3 months, and then at least annually with the persons that are actually doing the interventions and working with the patients. The next thing we want to talk about is basically what quarterly site reviews are. Quarterly site reviews are important. When they saw me coming, I'd bring donuts. I was part of their team. I wasn't the state person coming in and telling them what's wrong or whatever. I was helping them out. My job was basically everything, from administrative to being doing clinical supervision, because they may have a problem with a patient or whatever. They would ask some advice on what kind of motivational techniques that they could use, or giving them some advice. Even though you're there as a healthcare educator, you still have your abilities as a therapist or whatever. But remember, you're there to provide the SBIRT services. Now, when they return, okay, because a lot of your programs say, well, we can do 3 more sessions. We allow up to 4 sessions of brief treatment. Brief treatment is an interim between traditional substance abuse treatment and inpatient. It's like an in-between thing using motivational interviewing. You set a time aside. For those of you that are involved in that, maybe you've come into that problem where there's only 2 of you in the emergency room, and you're starting to build up a client load of people that are returning, that you have to do some further brief treatment modality with them. So I've worked up a plan over the years, and it has worked successfully for those of you do. Your day to do it is on a Thursday. The other person's doing screenings and on that Thursday while you're going in. Their day may be on a Wednesday, where they see patients. That's their time that they bring patients back. So there's always someone in that emergency room doing the screenings, okay, or in the outpatient practice. So, you know, it's going to be different in different type of settings. So in that quarterly site reviews, I basically went over the monthly statistical report, especially if you're still involved with SAMHSA and you're still within your 5-year grant period. You're still, they look at your numbers and they're going to ask why. Here you have 2 people in there, and each person in the ER is only doing 10 screenings a day. When you're seeing 100 people going through that ER, there's going to be a question. And I found out one time that was happening. I went in and did my site review, and here the person that was in there was from one of our drug and alcohol treatment agencies. They were embedded in there. They even actually gave her own little spot and her own little computer, and she was on the computer looking at the admissions to the ER room, and she was going through the stuff, and she was looking for signs to tell them that they were had a real substance abuse problem or this and that. And then when she found somebody, she was going down, she was almost doing therapy with them. But I nicely, you know, instead of saying, this is wrong, this is not what to do, so I talked to her about, you know, that's really great, but this is the focus that we need to do. And then I also talked to the supervisor. What she needs to do is she needs to go in there, click on the admissions, and anybody 55 and over, click out that list and go straight down to the ER and start doing the screenings. But she was, you know, 20 years as an addictions counselor. She was, you know, that's not what the SBIRT is when you're there in the emergency room when you're doing this process. Unless you're going to be the outside agency that they're going to refer to if they're at high risk, you know, and they have a memorandum of saying that you're going to provide the substance abuse treatment right there on site. That's a different story. But I'm talking about if you're being paid by SBIRT funds and you're that person there that's supposed to be doing screenings and brief interventions with the patient. So in that statistical report, you look at the numbers because those are the numbers that are going to be going into SAMHSA, and SAMHSA watches that, okay? I'll be honest with you, all these years I know that. And those of you that have been doing this know that also. Also 6-month follow-up completion updates, I go over that. I go over because they have folders for the 6-month follow-ups. They have a tickler file. We help them develop a tickler file when that's due, when the letters are supposed to go out, or notifications. Also, on the 6-month follow-up completion update, you know that if they're not available and they can't come in, you can do that over the phone. SAMHSA allows you to do that 6-month follow-up over the phone, and that's that 6-month GIPRA that I was talking about at the very beginning that has to be done. Then sustainability, we talk to the sites about, you know, what plans they're working on as far as sustainability of the project. Then I give them any technical support myself if I need to call my IT person to help assist with the problem. Maybe the software isn't working properly. We've had some glitches because a lot of times there's different firewalls in the agency and it interferes with the program that we put onto their computers, and we work that out. Then we would talk about training, what they would like to see in training, what they need in training, what they would like to see in the future from us at the state level or the county level. This can be done as a county person. Then we would talk about other issues that would come up. And then I would go out and I would visit some of the implementation sites, especially if the meeting was not at the actual you know, hospital. It could be at downtown offices or whatever. But we go out and just visit the sites, and I talk to the healthcare educators and people and say hi. And I make sure that I'm there to support them. I'm part of their team, and that this is a team effort. And I'm not the state guy coming in and telling you, you know, you're doing things wrong or whatever. So that basically is those quarterly site reviews. Okay. Now what I want to show you is another this information you need to take with you when you go to that very initial meeting to solicit the hospitals for if you're going to solicit hospital. It's much easier when you go to practices, physician practices, and it's much easier when you don't have the gift risk. We've done that in Pennsylvania, where we went to physician practices where they have multiple physicians, and they've gotten involved. This one physician was very involved in this. And even today, when I see my own physician, I found out my physician when we talked about what I did, for Florida and what I have done over my career. He shared with me that he monitors, he does a detox at a treatment facility here in Florida, which was really neat. We talked about it, and he's actually implemented the screening tools in his practice here in around where I live. So this can be done. I mean, now the money reimbursement is going to be different by state. Okay, that's an important factor for everyone here. But as licensed mental health social workers, there's other codes that you can use, and they are now working at trying to get some other codes for other than licensed individuals getting reimbursement. That's hopefully in the future. But what we have now is everyone knows about the CPT codes that you have, the procedural codes that you can use for screening brief interventions. It's a different cost. If it's 15 minutes, it's this amount. If it's over, the 30-minute, it's this amount. Those are available in most of your states. But also check your insurance companies. They do provide that. Most of them do. I was surprised at the ones that really do. You can get on the internet. That's how I got on the internet and found out about Virginia's. One of their key, I don't know whether it's Aetna or whatever it is, one of their key insurance carriers does pay for screening and brief interventions for substances. And so that's a key factor. The other one, in order to sell this to the hospitals, okay, here's the first one. This is taken out. I've taken some pages out of the manual for the Joint Commission. And the name of the manual is the Specifications Manual for National Hospital Inpatient Quality Measures. Back in 2011 or so, we were involved, some of our sites were involved when Jacob came to Sampson. Sampson came to us and says they want some sites to try this out, to see a pilot project and to see if it's going to work. Well, after it was done, first they thought, we're not going to do this, but then they did and became effective. This was in January 2013 that all hospitals are going to be screening and doing brief interventions and treatment for these issues in order to get their recertification through JCAHO. As you can see, tobacco use screening, tobacco use treatment provided or offered. These are tobacco use treatment. Now, this is for tobacco. Okay. You can see there anybody that's admitted into any of the programs, whether it's their inpatient, outpatient, family practice, or their family centers, whatever. Okay, in that hospital. Okay. Now that's for tobacco. That's why, if you look at that informational manual, it's called the Introduction and Information that Chris sent out. You'll see in there, you'll see the assist, and you'll see that tobacco is listed on them for the respond. Now, assist looks long. When you look at it in that manual, it looks long, but there's only 8 questions there. And those go on the tablet PC. So when you're asking, you just click on the answer with your little pencil there on the tablet. And the tablets look like a piece of paper. People are used to having people take notes. And you just click on it, and then after everything's scored, the the assisted sport, and for us it's the short version bariatric compression. All the interventions come up on the little screen and tells you exactly what to do and what the scores are. And those are saved because that data information goes down to SAMHSA and over, again, like I say, to your evaluator. So this is for the tobacco. And here are the measures for your alcohol and other drugs. See, alcohol use screening. See, it's not just now just alcohol abuse or dependency. Again, that's what the whole SBIRT was about, to cover all aspects of use. And if you use the cage, for those of you that have been using the cage, I've been in this field for 39 years, mental health, addictions, behavioral health, and cage has been a long time ago. Cage was developed for looking for the dependency. You want to find people that are into misuse. You want to stop that cycle. So it's an important part. So as you see, alcohol use screenings also for your brief convention provider offer, and that's why your health insurance are going to this. Everybody's bought into it, that they save money. And they save money in treatment and sending people inpatient treatment. If they can identify people that are on the verge of misusing their prescription medication, especially with the 55 and older population, that's one of the issues that we found. So addressing those saves them a lot of money. At the University Hospital in Hollywood, Florida down here, the ER director, she at my quarterly meetings would be there at all my quarterly meetings. She sit down and she really praised the staff. The staff was from the Broward County Veterans and Senior Services, and it was the addictions counselors that were going into the homes providing that. Well, they ended up with memorandum of understanding, and they have with the hospital, they're providing those services for the hospital in that agreement. And she's telling me how well the program is working, and how this one lady that was in there constantly in and out, which she found through the screening, she was having an alcohol medication misuse issue, and this interventionist worked with her for about 3-4 sessions, identified her being at risk, worked with her, and they hadn't seen her for like 8 months or so. And you know, in the follow-up, they did follow up in the 6 months. She's doing well. So those are the kind of things that you hear about, and those are the people that are sitting in the waiting room, always moaning and groaning because they're the last ones to be worked on, because priority is those people that are really sick in there. A lot of the people that are in there because of fall, the older population, is because they were drinking or they misused their drugs and they're a little woozy and they fell. So, like I say, it's the SBIRT pays for itself in a lot of different ways. So as you can see, these are for the alcohol. There's more to it. I just picked out a couple of pages to show you that this is a fact now. So if this is a requirement joint commission and it's going to be done and it saves money, the insurance companies are going to jump right on it, and they're going to say this is a great intervention. Like they pay for smoking cessation classes now. You know, I don't have, if I smoke, if I wanted to go to those, there's no copay for me to go to those. So you know, it's the right thing to do. So basically, I wanted to leave the last 15 minutes so here open for any questions. I hope I covered a lot of your questions already about this. So Chris, I'm going to go ahead and leave it open for the question.
Okay.
Before I do, I'm sorry, Chris.
Go ahead.
Here's the information. If you're interested, visit our BRITE website through University of South Florida, or they're the National SBIRT ATTC, IRETA, or if you have any questions I might be able to help, just email me.
Okay, thanks so much, Bob. I just had one person write in a question. If anybody else has questions or comments, please do that now. They just asked, how do you present the screen to patients? I think you might have gone over that somewhat, but could you just elaborate on that a little bit?
Yeah, there's different ways of presenting. Did you say the pre-screen, Chris?
Well, just how do you present the screen?
Okay, there's a couple methods. The first method is by self. At the urgent cares, they put it on. It's called an extended patient healthcare questionnaire, and the 7 questions are on there, and they answer it, and they give it back to the receptionist, and she scores it for the medical assistant that takes them back into the room, and then she administers the screen, which is the assist. Some places it's the audit or the DAST or whatever that you decide to use out of the evidence-based approved screens. Okay, that's one way. The other way, again, is the interview process of asking those questions. Maybe the person that's doing the weight, taking the weight, can ask those questions and throwing the weigh-in, or some other questions there. There's 2 things. The pre-screen, if you have time, like for example, your social service agency, you go and do an intake. This patient was referred to you, or this person was referred to you through the Department of Human Services for, it could be for maybe they want to investigate for neglect of a child or whatever, but you always have your intake paperwork. That can be taken with you, and you can do the screen itself, the 8 or 9 question screen. You do not need a pre-screen. The pre-screen is used for where there's large volumes of patients. And again, it's right in the questions, in the health questions on there. And there's actually needs no explanation when it's introduced into the hospital's form. But if it's introduced into a separate form, there's always a paragraph at the very top saying, this is an extended healthcare questionnaire. We're wanting to know your use of prescription medications. The reason for this is that the physician may, in the drugs or medication you're using may interfere with the treatment that he may provide, so he needs to be aware of what you're using as well as any illegal medications you're using, because your health is vital to us, and this is confidential information with your healthcare team. Okay, so that goes on that form, and that form is given to them to fill out, or the person takes them back in and says the spiel, gives them, tells them what's in that paragraph in their own words, and says, would you mind me asking any questions? They're related to your use of alcohol, prescription medications, and even illegal medications like marijuana or other drugs, because it's very important for the doctor to know this, and it's very important for your health. And the number 1 reason we're asking this is for your health. That's the way it's presented. And you find very little resistance. I mean, when I go out and I do those quarterly site reviews, I collect all that information. How, from the healthcare, how are people taking this? Are you finding resistance? Because if you've never done this before, most people think, oh, you're going to be asking about drugs and alcohol. Not in the way you're thinking. We're asking about their health, and we're showing them that how the alcohol can affect. For example, here, that's why the charts are very important. When I find out that they're having some stomach problems, and they share that with you, and here they're at moderate risk, and here on that chart it shows about gastritis and those other things in there, and that if they continue their use of alcohol, then you may have some problems here with your liver, your stomach, and all this stuff. And then sometimes they say, oh, that's why I'm here, because I'm having some stomach. Well, that's why it's important for us, why we ask those questions of you. It's more health related. That's the focus. That's why, again, you need to introduce yourself as the healthcare educator, healthcare advocate, you know, you got to watch your ego things, you know. I don't walk and say, I'm Dr. Bob Hazlett, and I'm an addiction counselor, and I'm going to be asking you some questions about your use of alcohol and drugs. And boom, the wall goes up. I walk in there. I've done this in a memory for this one nurse. Within 5 minutes, I had this lady's life story. The nurse said that this lady's been in here before, and she knows that there's something there, but she can't get anything from her. Well, that's because the way the nurse approaches her. She had a gruff way about her. The way I approached it was, hi, I'm Bob. I'm part of the healthcare team, and I'm just going to ask you these questions. They're extended questions, healthcare questions, and at that time we only had like 3 questions. She shared that she was an alcoholic, and she had a slip, but she was going back to her program. I mean, I got that out of her, and she's been to this nurse 3 different times. Again, it's your approach to this, and your approach to the patient, showing that you're caring, you're concerned, and you're providing them vital information about their health. That's why it's in those type of settings. And even in social service settings, it's important when you do ask, how do you feel today? Can you tell me how your health is? Or whatever the questions are there, all you need to do is add those few questions there and get trained. And most of these social workers have training in motivational interviewing out there, and just learn how to do it as far as the SBIRT process is, and you're already there. And again, like the physician told me, it's the right thing to do. And because we know that not only are you helping a person's health, but you may be preventing a child abuser, a future child abuser, because they may cross that line over into that addiction phase. So anyway, I don't want to get on my soapbox here, but is there any other questions, Chris?
No, I think you answered the one that was there, so you must have done your job, because there aren't any other questions. People don't have anything else, no other concerns. I will tell people, though, before we close today, that about 2 hours after this webinar, you will receive an automatic email from GoToWebinar with our evaluation on it. We really need you all to complete that. It goes into our funders, and they need to see what everybody thinks about this webinar and how it's being handled. Tomorrow morning, you will receive from me another email that will include the CEU order form link. It will also include a certificate of attendance for anybody who doesn't need the CEUs. And if this file isn't too large, it will also include the PowerPoint. If the PowerPoints don't go through, you will be able to download those and also see this recorded webinar on our webinar library page at www.ireta.org. Just go to Webinar Library and you'll see all our previously recorded sessions. And beyond that, I want to thank you all for participating. I've added another 1 or 2 webinars just recently on the webinar page, so please check those out and register if you're interested in attending those as well. Okay, Bob, I will say thank you once again for being on this webinar for us, and thank everybody for attending. We will now close this session out.
Thank you.